Thank you very much. I'm really happy to be back here in Athens, and I want to congratulate the organizing committee for this excellent course. So we're going to have a look into the critical glenoid bone loss and the decision making. And this is the holy grail, how much is the critical bone loss. However, we'll see further down that things might not be as we think. So classically, 25% of bone loss was found to lead in increased redislocation rates after bunker repair. That came down to 13.5%. However, the measurement methods are several, and they were based on 2D and 3D CTs. They were linear, surface, or statistical shape module formulas. However, it was found from several papers that most of the methods overestimated the defect by 5%. So this study compared all those methods, and they found one of the best ones was the Barthilon method, if I pronounce it well, I don't know. And this is a surface area method, and it's the one on the third row from the top. It measures the surface of the glenoid minus the total surface of the defect. And it seems this to be the best accepted method. And however, so we're still looking for the critical bone loss on the glenoid and try to translate on what does this mean. Sin with his colleagues found a 17.3%, and it seems that 43% of patients above this value experience surgical failure, and only 3.7% of the patients below that redislocated. So that was quite a good study. And there have been also biomechanical studies, and also there have been statistical studies as well. However, this came a big cohort study and from Colorado with looking at subsequent bunker repairs and glenoid bone losses. It seems they defined the 15% as the limit, however you can define it, of the critical bone loss. So they measured with a similar way as the Barcelona method, a surface area method with based on the CT scan. And from these patients, the 16.6%, 46.6% had no glenoid bone loss, and 53% had glenoid bone loss. And they defined the limit for glenoid bone loss 5%. If it was less than 5%, there was no bone loss. More than 5%, that was bone loss. So what did they find? They found that the mean amount of bone loss on the glenoid was 15%, and the first group had 9.9% dislocation, comparing with 4.9% and 4.9% subluxation. And if the glenoid bone loss was more than 15%, these patients had 3 times greater odds of recurrence. Also, they found other factors, was duration of symptoms, more than 5 months, and younger age, less than 20 years. All this described now by the literatures agree with everybody's observations when we practice, and you see patients who dislocate more, they have more damage on the cartilage, more bone losses, more fraying on the labrum, less. So all that reflects the more dislocations, the more damage we get. So what do we know up to now? Glenoid bone loss is critical for increased recurrence after arthroscopic bunker repair. There are several ways to measure it. The best seems to be a glenoid surface measuring way. There is always a 5% overestimation of the glenoid bone loss. And it seems that 15% is the number that we've been looking for, the critical bone loss. However, there are more studies coming saying that does the size measurement really tell it all? It seems not really. Everything we've discussed up to now, it is collapsing, and there are other discussions, and as we already heard, it's not just the bone loss of the glenoid, there are other factors as well. So there was a study as well in the American Surgeons Societies, and they tried to find if there was an agreement regarding the decision and how they would treat patients regarding looking at the bone losses. And there was a survey given out. First was with questions related to demographic characteristics. Second, assess how prognostic factors would affect. And they looked at normal bone stock, humeral bone loss, erosive glenoid bone loss, and bipolar bone loss. And again, it seems, although they agreed in the easy cases, in the difficult cases, they did not agree among them. And that had to do also with the experience of the answering surgeon, whether it was a trainee or somebody more experienced. So here we come to the most important thing. Why are we discussing all that up to now? And why are we looking at this today? Because it is decision. How do we decide what to do regarding the glenoid bone losses, but also the other factors that we find regarding the heel sacks and everything else. So where are we now regarding the decision? We've seen the ISIS, we've seen the very other nice new score that's coming out. I think there are three circles, and that we have to combine all that in order to find out what's best for our patients. I think the first one depends on the surgeon's experience. If you are born and bred in France and you do only lateral Z's, sorry for the French friends above us, you do only lateral Z, whatever it goes on. It has to do with your training background, how you've been practicing. You like some techniques more than others, you prefer. That also affects your decision. Also with the surgeon setting. Is your practice something on a research teaching hospital? Are you on private practice where you are, you have to be more careful? And it's the patient's profile activities. You treat the patients different regarding with their activities. You don't treat them only for how the CT scan looks like. And of course, if the bone loss, the one we're discussing up to now. The other column is what we find on the CT scan. And it seems if there is no bone defect, it's easy. Everybody agrees. We go for an arthroscopic procedure. Previous surgery and defects, again, that's easy. We'll do something that we are confident will be the most stable situation. And now things get more difficult when there is combination of defects. That was an excellent talk before. We see how to overcome this. And the other thing is there an objective measurement? All these methods are good, but they do overestimate about 5%. And we've seen papers that question all this as well. And which is a critical bone defect we come from, which we searched from the beginning. And nowadays we have all those methods to decide what we'll do. We proceed with a labral repair only. We'll do bony procedures, we do lateral Z, we do Replica, we'll add ASA, or we'll do others. So I think if we blend all those together, that will be the result for surgery, for the best option for the patient. Thank you very much.